Hey guys, it's Dr. Davis at the Davis Medical Group in East Texas. Today, we're going to talk about dementia. Dementia 101, all the basics, everything you need to know, how to recognize it, what the different types are. If you love it, give me one of these down there. Click on the thumbs up. I would appreciate that. Leave me comments. I'll be happy to help it out in any way I can. And please click subscribe. Get on the YouTube channel. We're building the content as we speak, doing my best to communicate it with you. Basically, all my videos come from conversations that we have during the clinic. So, coming up, Dementia 101. First, let's talk about who gets dementia, or how old you are, what risk factors you have. The single most important risk factor is being over the age of 65. It's almost unheard of to have it below 65 for just basic reasons. But over 65, about 10% of the population over 65 are going to have it. When you get 90, it's 40 to 50%. So obviously there's a condition with aging that affects your mental function. And dementia is one of those things that happens that way. And women tend to get it more than men. Now, arguably, women live longer than men, so maybe we have the opportunity to catch more of them. So that there may be a logical fallacy there, depending on how you want to look at it. Other risk factors, chronic diseases, particularly diseases that affect the blood vessels. And we already talked about diabetes previously and how that affects the blood vessels, so that's certainly a risk factor. Previous stroke and damage to the brain, or cerebral vascular disease, blocked arteries at the heart level and blood delivery to the body, so that's coronary heart disease or heart disease. You know, I have a degree in molecular biology, so I'm always thinking at a DNA level. That's kind of what my brain rolls in. And there's a genetic testing that we're doing nowadays. And many of you have had your testing done DNA-wise. If you have the ApoE4, if you never heard of it, don't worry about it. ApoE4 gene allele seems to have some link to increased incidence of Alzheimer's disease. I'm sure there's more to come on that in the future as we get more and more DNA sequencing. We start figuring some of this stuff out. So next we got to talk about the different types of dementia. You've heard of Alzheimer's, you've heard of dementia, you've heard of vascular dementia, Lewy body dementia. Oh my goodness, which one do I have? Which one does my family member have? There are significant differences, and it can be a diagnostic challenge for sure to try to figure out which one it has. The most common type, about 65% of the time, it's going to be Alzheimer's dementia. That's good old-fashioned dementia that most people think about. And you know, it's classically seen with short-term memory loss, aphasia, which is it's difficulty expressing yourself and understanding, whether that's understanding things that people are saying or jargons or idioms, or being able to say words or find vocabulary words. So short-term memory loss combined with a difficulty with expressing yourself or understanding what people are saying to you. And finally, apraxia. Apraxia is the term for not being able to do things right. Either you get them out of order, or you can't function the device, you can't make the device function. And so getting dressed, cooking, driving, copying something, drawing something. So when we do our tests in the clinic, we always have people draw a clock and put the numbers in there. Well, if you can't do that, there's a problem with apraxia, and aphasia for that matter. If you can't write a sentence, we always have somebody write a sentence. So in the clinic, we use a mini mental status exam as a survey to see. We do it on everyone at their annual wellness visits. That's the first type, Alzheimer's dementia, 60 to 70% of the people. Then we have the vascular dementia. When the brain takes multiple small insults, areas die. It almost be like dropping little grenades in a city. Over time, eventually, many of the houses are destroyed, and it accumulates to decreased brain function. So vascular dementia tends to affect two major things. You have slowing mentally. Everything's just very slow to do, very difficult to get stuff done, and mood issues, changes in your mood. Those are the two classic symptoms of vascular dementia: mental slowing and mood disorder. The next one is very interesting. It's a metabolic dementia. The reason when you start having memory problems, you come into the clinic and we do a full battery of tests. We're just checking all kinds of stuff. We're checking thyroid, we're checking vitamin levels, particularly B12, and we're looking for a reason, something we can reverse. Did you know that 10 to 20% of the time when we think it's good old-fashioned dementia, it's reversible? Why? Because of metabolic dementia. And vitamin B12 would be the big boy there. But it's not, you know, how often does that happen? Not always. In my practice, everyone's on B12, so we keep that in check. But Alzheimer's dementia, vascular dementia, metabolic dementia. The fourth type is Lewy body dementia. Lewy body dementia. You see these Lewy bodies on the MRI, and you know you're in for a world of hurt. There's just no turning back. And Lewy body dementia is devastating. A lot of hallucinations involved with Lewy body dementia. Classically, it's Parkinson's type disease, rigidity, difficulty moving. The body doesn't function like it's supposed to, combined with all the other parts of dementia: short-term memory loss, aphasia, apraxia, the things we mentioned above. Next, we have frontotemporal dementia. Sadly, this part of your brain makes you who you are. It makes you have certain beliefs and political leanings and rules to yourself, and the language that you use, the things that you might say that are appropriate to people. If your front part of your brain gets affected by a tumor or a stroke or dementia, it changes you and you become a different human being. If you were a preacher, you might be the opposite now. If you were a Democrat, you might be a Republican, and vice versa. You might have been quiet and soft-spoken, and now you're not. And it's very socially inappropriate behavior, and it's so embarrassing to the family, but the person who has the problem just can't help it. It's just the way it is. So that's frontotemporal dementia. That part of the brain just got affected most. And then finally, we have mixed dementia. You get vascular dementia over time, you have slowing and mood issues, and then you develop classic Alzheimer's dementia, short-term memory loss, difficulty expressing and understanding things, and difficulty completing tasks and following orders and following steps. And so those are the types of dementia. Those are the 6 major types. Okay, so what does it look like in the clinic? If somebody comes in here and they have a sudden change and it matches these symptoms that we mentioned earlier, that's something else. There's something going on, probably stroke or tumor or something, or metabolic problems outside of a slow vitamin deficiency. That's different. Dementia is slow. I mean, I had a patient today, and I told her to watch this, so maybe she should be watching this. I had a patient today that said, my family's starting to notice that I'm forgetting things. We'll have a conversation and I won't notice, and I'll be like, well, it takes a while for that to develop. And she goes, yeah, and it's been happening for about 1.5 years. That's what we're talking about. It's slow. It builds over time. The symptoms are long in duration, slow in onset. And so we're looking for that kind of pattern of coming on slowly, developing over time. We don't want anything that develops suddenly to be calling it just good old-fashioned dementia. The other thing is that the person with the problem, there's 2 things. One, they look normal. Vitals are normal. Labs are normal. They're normal appearing. But there's altered content going on. And so that's what we're after. So I have I could just go through story after story after story of what this looks like. I had a husband and wife that neither one of them could function on their own, period. But together they made up for each other's deficiencies. So it was very fascinating. But the deficiencies were glaring when they were separated. I mean, glaring. And so if you're looking for things that are altered content, their brain doesn't work the way we want it to work. And so, again, remember, slow onset, long duration. Those are the things that we're looking for. So I'm going to get into a list here next of symptoms that will show up in real life and that you'll be able to pick up on. So what does it look like? Well, let's say you're doing what I'm trying to, what am I going to say? Oh, what's that word? Oh, it's yellow, that kind of stuff. You cannot get to the word. You cannot get to the thought. You cannot get to where you have difficulty expressing yourself. Aphasia, whether that's saying the wrong word. You're trying to say zebra and you say notebook or whatever. You're saying the wrong word, or you can't get the word, or you're always looking for your spouse. And that happens a lot. Spouses will solve the riddle before there's a problem. And so they'll cover for the other one in a loving way, not on purpose. It's just what happens. They know what the other one's trying to say. They can finish their sentences, and so they do, and they do it over and over and over again. And so you're not being able to finish your sentence, not being able to find the word. Maybe a change in irritability or aggressiveness that was never there before. You have now new irritability and new aggressiveness. That can be a very real problem. Complex tasks. You can imagine, let's pretend you were, I don't know, making a recipe, following a recipe. That's complex, right? There's a lot of moving parts there. And if you have a problem with processing, it's not going to work out well. You got the wrong ingredients in the wrong order, cooked at the wrong temperature. Those are the kind of stuff we're looking for. And you can translate that to any other task that's complex in nature. New information, like talking to somebody, telling them something new, a new address, a new phone number, a new thought, a new idea, working on something on a phone or something. Impossible. Not going to happen. If anything, they're going to throw it because it's going to be very embarrassing. Or they're going to cover. Even if you ask them who the president is, they'll just change the subject and they'll cover for it and they won't know that. And then you can't solve simple problems even. Very simple math problems or something they know how to do. They just can't. The hardest word for me to learn in medicine was this one. Anosognosia. Anosognosia. It means that the person with dementia isn't aware of their defect. They're not aware. And so a lot of times that happens. And so somebody with Alzheimer's, for example, will think you're crazy for telling them that they're not processing things or forgetting things. They'll say, you say, I told you yesterday. And they'll say, no, you didn't. You didn't tell me that. They legitimately don't know. And so I see a lot of caregivers or nurses even who will chastise the patient because they're like, I already told you this. I told you this 3 times today. And of course, the person with dementia doesn't remember that you told them, and they're not aware that they can't remember. So they think you're being mean to them. So it's very important to remember their problems are not intentional and that they're not doing it on purpose. Remember, it's not their fault. Their brain has slowed on them. Their brain is now not functioning normally. You have to be calm and patient. And I know it's very difficult when you repeat yourself 100 times, but they don't remember and they're not aware that they don't remember. Anosognosia is an important word to remember. Learn how to say it, spell it, because that'll be very helpful when you're dealing with somebody with Alzheimer's. You got to remember they don't know what they don't know. All right, so moving on real quick. I think that you come to the clinic and you're like, I think I got a memory problem. First, we're going to do some labs. Then we're going to do potentially some imaging, whether it's a CT scan or preferably an MRI. An MRI is your best bet because you can pick up on all those little things and see a lot more microscopic damage. I think that, or we may send you to a neurologist or a neuropsychologist for a further evaluation. Certainly memory impairment requires significant testing. You know, if you go to a neuropsychologist, the testing can be 4 hours. And you can imagine how difficult that would be with somebody with Alzheimer's. It can be 4 hours of focus and attention trying to test them, but that's just what you have to do. There's no blood draw. There's no magic pill that can tell us that you have it or not. But this is important, and I mentioned it earlier. 10 to 20% of the time is metabolic dementia. And so we're really digging in with our lab work trying to figure out if we can fix this. Unfortunately, many times we can't, but there's a lot of diseases that can do that. So what can mimic dementia and fool us, or try to fool us? We'll call them the tricksters. So the tricksters would be psychosis, some kind of psychological illness that's not dementia, but it's making you appear to not be functioning normally. That happens. Delirium can be caused by infection, change in your electrolytes, dehydration, infection, illness. There's so many things that can make you delirious, and that's a short-term problem that we can solve. It's very complex. I have a patient right now who's delirious and demented, and so where's the line there? But you can tell, the family can tell the difference between their normal state of dementia and this delirium, and so it's important. Family can tell. Family can cover for them, or family can really spot it. A big topic, and I go back to my 3 phases of a physician's career. The first 7 years figuring out what medicines to give people, the next 7 years figuring out controlling all the medicines that you gave people, and the next 25 years removing medicines. And as your patient population ages, man, those medicines become worse and worse and worse. And there are certain medicines that are particularly bad to mimic dementia. Bladder control medicines for sure. And we use lots and lots of people have bladder control problems, and we put them on bladder control medicines, and they're notorious for causing dementia-like symptoms. And so there's a full list, and your provider should know that list and should be able to look at your medicines and be able to pull away the ones that could be mimicking dementia. So medicines can certainly cause a problem, whether they're tranquilizers or pain medicines or depression medicines or bladder control medicines or even antihistamines like Benadryl can really rock your world. So you need to bring all your medicines, even your over-counters, into the office and let your provider look at them. So finally, I want to focus on something that's probably the most crucial part of treating a patient with dementia. It's more important than anything else, and it's not the patient. It's the family, it's the caregiver. A lot of times that's a spouse, whether it's a husband who's been doting on his wife after she doted on him for a long time, and it's a heavy burden, or it's a wife who's always cared for her husband and now she's carrying a whole lot more. This is one of the saddest things that we deal with in the clinic, because that person is so loving and so caring, but they're frail too. You know, they got their own medical problems, but they have to be the primary caregiver for somebody who cannot be left alone, who cannot be safe without constant monitoring, who's constantly doing things that jeopardize their health. They forget their limitations. And so caregiver stress, caregiver burnout, caregiver emotional turmoil is dramatic. It is so hard. And then you feel so guilty as a caregiver that you don't do better, or that you're not always there, or if something bad happens, you blame yourself. I mean, it is a beat down. And so, talking to you caregivers, you're angels. Give yourself a break. It's not your fault, and you're struggling, and you need help. You need help. There's some big missing areas, I think, in our healthcare industry, and I think that's this gap between home health and hospice care, and I think there's this gap in families, husbands and wives, who just don't have enough help. Maybe they didn't have kids. Maybe their kids live far away. Maybe their kids don't understand how hard it is, or maybe the caregiver has covered up so much they don't understand how dramatic it is to change clothes all day long and to always have to be aware and, you know, have to constantly be paying attention. I guarantee you, locally, there's an Alzheimer's association near you. Call them. That's what they're for. Most of them are not for profit. Most of them are people who've been through it. They do dramatic things. They have their own funding. They can do their own testing. They can do such wonderful things for you. So locally, I live in Smith County, Texas, and so we have the Smith County Alliance, and it is amazing. They've done wonderful things for my patients, more than I could do myself for them. And they offer support and care for the caregiver. I do a lot of hospice and home health as well. Home health has a ton of support for dementia patients. And then when you get to a certain point and your dementia is so bad, hospice is wonderful for dementia. But you got to get pretty bad off to get on hospice for that. But once you do, certainly hospice has lots to offer for dementia caregivers and spouses. That's what support is really for. I mean, what are we going to do for somebody with progressive dementia? Keep them safe. Keep them safe. That's all we're going to do. Don't give them medicines that make them sick, and keep them safe. But we want to offer lots and lots of support to the caregiver, the spouse, the loved ones, the family. And you got to rally the troops. You got to tell everybody. So if you live next to somebody who's married and is taking care of a dementia patient, they need more help than you think they do. Check on them, help them, offer to sit for a while. And I guess my final piece of advice across the board here is people with dementia need a no-fail environment. They need a no-fail environment. They need to do the same behavior every single day. They need to do Groundhog Day. They need to wake up at the same time. They need to have the same breakfast. They need to have the same newspaper. They need to have the same whatever. And they need to go to bed at the same time. And they get adjusted to that and things are good. If you really want to see how bad it is, pull them out of that. Go on a trip. Admit them to the hospital. The changes cannot be handled. It makes such a dramatic change in their life. It appears all of a sudden that they got a lot sicker. Well, they didn't. They got into a gonna fail environment and didn't stay in a no fail environment. So that's enough about dementia. I want you to know all these basics. So that's why we call this Dementia 101. Please like and subscribe to my YouTube channel. I'm going to keep building the 101s until we have all the major diagnoses made. And then we'll dive deeper into more out of the box thinking, maybe even alternative practices. And so we're going to get there. Have a great day.